again, lung cancer screening, a little bit of the Duke experience. As a matter of disclosure, I'm a member of the NCCN Lung Cancer Screening Guidelines panel. I'm not compensated for that, but I will be discussing the guidelines during the talk today. And just by a show of hands, how many of y'all have lung cancer screening programs in your institutions? How many don't? A minority, okay. How many programs are either run by surgeons or heavily involved with surgery? Okay, thank you. And geographically, how many of y'all have insurance coverage for screening? Not much. All right. So I won't talk long about background and rationale for lung cancer screening, but really more about launching a program, some of the fundamentals and logistics that we talked about in developing our program, and really some of the challenges that we encountered. And we'll touch on some future developments and hopefully ways to make screening more widespread and applicable for all. So this is obviously the reason we're here and talking about screening. It's, I think, very frustrating as a surgeon and really as a human being to encounter a patient with stage 4 disease that I can't do anything to help except palliate their symptoms. And we all know that earlier stage means higher survival. So I finished my training in 2008, and I can probably count on one hand the number of conversations that we had during the entirety of my training talking about screening and the utility of the various modalities. And I think really it wasn't until the NLST came out that the momentum and the discussion really regained popularity. And when I talk about the study with our residents, I think some of the really big points are that low-dose CT was much more effective in diagnosing lung cancer than chest X-ray. But not only that, the stage at which the lung cancer was diagnosed was much lower and much more treatable than with chest X-ray. And we all know the 20% reduction in lung cancer specific mortality with low-dose CT, as well as the nearly 7% reduction in overall mortality. So at present, all the various organizations with any interest in lungs or cancer have come out with some sort of statement or guidelines with regard to lung cancer screening. I think that probably the most lax of these come from the American Cancer Society, which urges clinicians with access to high volume, high quality screening to have a discussion with patients who are high risk. That's probably the least specific and the most general, I think. The NCCN guidelines are much more specific in terms of patient populations who are at risk and who should be screened. And finally, the United States Preventive Services Task Force came out with a Grade B recommendation over the summer recommending screening, and that I think is going to be another game changer for us. In the paper that accompanied their recommendation, they made some comparisons. 320 people need to be screened for lung cancer in order to save one life, and while that might seem like a lot, comparatively speaking, mammography and colonoscopy both need more. So their recommendations differed a little bit from the NCCN. They recommend that anybody between 55 and 80 be considered for screening if they're either current or former smoker, having quit within the past 15 years, and have at least a 30-pack year smoking history. So I'm going to switch gears a little bit and talk about how we established our program at Duke. Some of the early considerations that we had in our conversations really in mid-2011 before the NLST came out were among a couple of us in surgery and certainly with the hospital and the Cancer Center Administration. If we didn't have buy-in from them, we weren't going to have a program. Obviously, it was important also to get buy-in from the chest radiology group. Our group in particular tends to be very divergent in their opinions on screening, and we've actually had two very senior radiologists who have not only spoken and published against screening, they've opted out of participating in our program. Once we established a framework for our program, we discussed it with the other specialties in our thoracic oncology program, including interventional pulmonary medicine, medical oncology, and radiation oncology as well. So some of the things that we talked about and hashed through were patient workflow. We have one surgeon in the clinic every day of the week, and we knew that we wanted to have the screening clinic in parallel with that, but we also didn't want to impinge upon the flow of the surgical patients. And we also had a lot of discussion about how much interaction we were going to have with the patients, talking about results. Were we going to have a mammography model where they paid their fee, got their study, and went home and got a letter in the mail? Or were we going to have an actual in-person interaction with them and a discussion of the results and potential sequelae? And finally, once we decided on a program and how we were going to do it, the final consideration was how we were going to let other people know that we were doing it and to capture patients. So this is our cancer center. As I mentioned, we have a surgeon in the clinic 5 days a week. We have a medical oncologist in the clinic 5 days a week. Radiation oncology is there 4 out of 5, and starting in July, we'll have interventional pulmonary medicine 4 out of 5 as well. Radiology is housed in our cancer center as well. So we're trying to make it as much of a one-stop shopping and as easy for the patients as we can. So we're a multidisciplinary program. I'm co-director of our program, and I'm happy to be co-director. My other part is the section chief of chest radiology. And we communicate and we talk a lot, and we have a great rapport, and I think it's really important to not have fences and barriers when you have a program like this. And obviously the primary care physicians are a very important part of the puzzle as well. When we set up our program, we decided that we were going to have an in-person consultation, there's just too much and too much worry and angst with having a patient get a letter in the mail and reading about a nodule and thinking that, oh my gosh, I have cancer because they have a nodule. We have a shared decision-making model where they're actually counseled before they get their scan. We follow the NCCN guidelines, and part of our program, again, is smoking cessation counseling, which I think is another big fundamental part of it. And finally, another part of our discussion was what we would do with incidental findings, anything that's not a pulmonary nodule, and how we would handle that, whether we would just kick it right back to the primary care physician to handle, or whether we would make appropriate referrals through Duke. So patient logistics, before they come in, we ask them a series of questions just to confirm that they are eligible for screening. We don't want anybody to waste a trip and pay for parking when they don't have to. And in terms of patient workflow, the patient comes in, they have a discussion with us before their scan, they have their screening study, and then following that, the radiologist will report those results to our provider within an hour. And so in that time, we use that opportunity we use that as an opportunity to provide smoking cessation counseling with a certified tobacco treatment specialist, as well as to discuss the results. And at the time of that discussion, if there are any follow-up appointments that need to be made, we do that, either repeat screening in a year versus any referral for nodules or other positive findings. So this is just a little schema of our workflow. The patient calls, we confirm that they're eligible, their screening appointment is made, and that sets off a call or a notification to 3 of us, the chest radiologist, our nurse practitioner, who's our tobacco treatment specialist, and really is the backbone of our screening program, as well as to me. So on the day of screening, the patient comes in, they have a discussion with our provider to talk about risks and benefits of screening, their motivations for seeking lung cancer screening as well. That's their time. If they ultimately decide they don't want to have a study, then they can opt out at that point. We've yet to encounter somebody who chooses to do that. Then they go to radiology, they go to downstairs to get their scan. Again, the scan is read by our chest radiologist within an hour, and the results are reported by telephone to our nurse practitioner, who reviews the results with the patient in the clinic. So it's a little up, down, up in terms of actual physical travel for the patient. But again, we feel that having some discussion prior to their scan is really important. So if the patient has a negative screen, then they discuss that with Kathy, our nurse practitioner. They're scheduled for their next annual screen at that time, and a letter is generated and sent to their referring physician as well. If it's a positive screen, as per the NCCN guidelines, then that sets off a different path. We go down a different path. As I said, we've got a surgeon or an interventional pulmonary provider in the clinic every day of the week. If the positive finding is a nodule that needs to be followed in a few months, then an appointment is made for the patient to be seen in whichever surgeon is on call that week. That way we know somebody's in town, and it's an equal distribution of patients. If there's a finding for which the patient needs to or wants to be seen that day, then the surgeon is, or the interventional pulmonary physician is able to see the patient that day and add them onto the schedule. If the finding is consistent with something advanced, then Kathy will set up the appropriate biopsy and referral to medical and radiation oncology. So for all the awful things that Philip Morris has done for public health in the United States, I actually think they got it right here, talking about an ounce of prevention being worth a pound of cure. And I want to spend just a couple minutes talking about the importance of smoking cessation. I realize it's a little bit of preaching to the choir, but I think it's really important, a really important component of a screening program. So at present, about 20% of the United States population are smoking, a little bit lower for women than men, but pretty consistent over the past several years. And this is one of the early studies that followed from the NLST looking at cost effectiveness for CT screening, looking for lung cancer. They used a fairly broad population, and it's again based on modeling, but 50 years of age with 20 or more pack-year smoking history. And they looked at the cost effectiveness of smoking cessation alone versus screening without smoking cessation, and smoking cessation alone versus screening with smoking cessation. And I'm not an expert in cost effectiveness studies, but it's my understanding that anything that's less than $100,000 per quality adjusted life year is considered to be cost effective. So by their estimates, annual CT screening alone was anywhere from $126,000 to $169,000, so not cost effective. Smoking cessation can be range from either cost saving to $17,000 per quality adjusted life year, so very cost effective. Again, in comparison, looking at colorectal cancer screening and breast cancer screening, this being for women over age 40, these two modalities fall well within the realm of cost effectiveness and much lower than what they estimated for CT screening alone. And so the authors concluded that unless screening participation increases the chances of smoking cessation, that it's not going to be cost effective and really not going to be, essentially not going to be covered. This is a more recent study where they used LCAP and NLST data, again, to estimate cost effectiveness for low-dose CT screening and treatment. These authors included various cessation programs and various intensity of cessation. So using light intensity counseling versus moderate to higher intensity smoking cessation means ranging from nicotine replacement to bupropion or varenicline. They had a hypothetical cohort of people aged 50 to 64 with significant smoking history, and they estimated that 2/3 of their hypothetical cohort were current smokers and 1/3 were former smokers. And this slide's a little bit hard to read, but at baseline, they find lung cancer screening to be cost effective. But I think what is more striking is that with any smoking cessation intervention, either light smoking intervention or more intensive, that it becomes even more cost effective. And so from my perspective, smoking cessation is a really big part of the puzzle. It is a fundamental, it has to be a fundamental part of the program. And for us, so much so that when one of our sister hospitals wanted to come on board and be part of our lung cancer screening program, we pretty much insisted that they bring on or have one of their providers trained in tobacco treatment counseling so that we could actually be true to our word. So I don't want to drag out all the skeletons from the Duke closet, but it has not been completely smooth sailing, and I want to discuss some of the challenges that we've encountered, really just to open the discussion and to help with those of you who are in the process of initiating or whose programs are early in their development. We've had some problems with logistics and patient workflow. We had one patient who was signed up and paid for a screening study who got a full-dose diagnostic scan. This was the result of a well-meaning night-float radiology resident on whose list of duties is to protocol the studies for the next day. That resident wasn't on their chest rotation, didn't know how to protocol it correctly, and that patient got a diagnostic study. I think the biggest obstacle for us is financial. At present, we charge $400 for a screening, scan, and consultation, which is not trivial for anybody, I don't think, but especially in the state of North Carolina. We've had a couple of patients, despite the fact that they paid for their study, get billed from Duke for several thousands of dollars because somewhere along the way, somebody or the system thought that it was a diagnostic study and a consultation with one of us. We as an institution transitioned over to Epic over the summer and have encountered a couple of challenges in terms of our workflow and bypassing the stops that we have had in terms of ordering studies and getting them through the clinic. Again, we don't want to be a drive-through, get your CT here operation, and we've had one patient who we caught, not that the patient had anything to do with it, but one patient who got their scan and wasn't able to be seen in the clinic because we just didn't know about her. We've had a couple, because of the cost, we've had a couple of our referring providers be really hesitant to discuss screening with their patients. I had one of our pulmonologists say, you know, I don't want to have them pay $400 out of pocket, so I'm not going to refer anybody for screening. We have had, anecdotally, an uptick in scans being ordered for cough or shortness of breath for indications that might not be real, that may be a curtain for screening. And unfortunately, those patients get diagnostic studies. They don't get low-dose studies. I had one Duke provider, actually in a patient who ultimately came to us. His Duke provider or his primary care provider is a Duke physician. They had a conversation about the fact that we do charge $400. It's more than our competitors, but it's all under one umbrella. One of our competitors is a radiology, diagnostic radiology center, and I can, while I've not been through it personally, I can nearly guarantee that they don't provide the entirety of the counseling and the whole package that we do. And finally, I think that as evidenced by the one or two people who raised their hands when I asked if their screening was covered, we've had, I think, some problems with getting patients into the clinic because it's not covered and because, again, $400 is a lot to pay. So at present, Aetna will cover lung cancer screening for the high-risk populations. Blue Cross Blue Shield will cover depending on where you live. And for us in North Carolina, it's not covered. You can see the number of providers who do not cover lung cancer screening at present. So, as I said, at Duke, we charge $400. About half of our patients in the hospital system are covered by private insurance, 35% with Medicare, and a not insignificant portion on Medicaid or self-pay or charity care. So those patients definitely aren't going to come for screening in the near future. And really just regionally, the state of North Carolina, we have more smokers than the rest of you. And in general, it's been demonstrated in many studies that smokers are, in general, of lower socioeconomic status, and I think, therefore, unable to pay for a study. This is really underscored. I love where I live, and it's a beautiful state, but we're not without our problems. We have a lot of uninsured patients. We have a lot of elderly patients living below the poverty level. And so there are a lot of people who should be getting screening studies who are not, in my opinion. So I spent a couple minutes looking at the future and how we can make things better and I think safer for ourselves and for our patients. One would be to expand our coverage, and this would be the ideal, in my opinion. CMS just finished their 30-day public comment period for low-dose CT scanning for lung cancer screening, and really looking through the comments there are a couple of negative ones, but they're overwhelmingly in favor of low-dose CT scanning for lung cancer screening. There are a number of professional societies, including the American College of Radiology, STS, the NCCN, who have also recently submitted a consensus statement in favor of lung cancer screening to CMS. So hopefully we will be heard. And really, again, I think we can expand screening. We obviously have patients that we need to reach, but we also need to reduce the risk of screening to them, because until we can make it as nominal as we can, there will be the detractors and the naysayers who say, well, it's not safe. Out of the NLST, 24% of the low-dose CT screens were positive, and of those, only 3% were true positives, so a really small number. And of those who were true positives, the vast majority of them got a repeat imaging study. 8% had some sort of intervention, which again isn't a lot of people, but it really sort of hits home when you look at the fact that there were 16 deaths within 60 days of their intervention, and 6 of those 16 people had benign findings. This study was recently published. Ned Patz is one of the radiologists that I referred to a few moments ago, looking at overdiagnosis in low-dose CT screening for lung cancer. And they make a good point that overdiagnosis does result in unnecessary treatment, morbidity, cost, and worry. And through their models, they estimated that screening for lung cancer with low-dose CT resulted in 18% overdiagnosis, which, again, maybe seems like a lot until you compare it with mammography and PSA for prostate cancer screening. So I think in order to reduce risk, there are a number of different things that are being done. One recently published was Dr. Henschke and the LCAP group looked at the LCAP data, and what they did is they used different size thresholds to measure the frequency of positive results and the number of cancers that were actually diagnosed. And using a 6 millimeter threshold, previously it was 5, but using a 6 millimeter threshold, they found that 10% of their studies were positive, but really there was no difference in the cases of cancer that were diagnosed. And so these influenced the NCCN panel, and 2 years ago when the guidelines were first published, the threshold was for 4 millimeters. It has, in the most recent iteration, been increased to 6 millimeters as the threshold for a positive study. 2 other studies I want to mention, one from the New England Journal last year using logistic regression models, using the PanCan data to predict the probability of malignancy based on size and number of nodules. And then this study looked at volume doubling time, using the imaging to predict doubling time and therefore to predict the possibility of malignancy. So the STS recently released a statement on the role of the surgeon in relation to lung cancer screening, and the quote that I pull, really the group encourages the use of minimally invasive thoracic surgery, either VATS or robotics, whenever available for the diagnosis and treatment of screen-detected nodules. And I know it seems sort of silly, but I think we as a specialty, even among true general thoracic surgeons, there's some of us who are divided on our opinion of minimally invasive approaches versus thoracotomy for lobectomy. And I think, granted, these data are a few years old. And I know, being from Duke, I look at the world through very VATS-colored glasses. But I suspect that VATS lobectomy and robotic lobectomy are still potentially underutilized. I think there are new technologies coming down the pike that will make things safer for patients as well. We've recently started using electromagnetic navigational bronchoscopy for both identification of nodules as well as biopsy. And one could envision that with better technology and localization of the nodules, that we might be able to do more safer studies or safer diagnostic studies, and potentially even save some patients from surgery. So we know that low-dose CT is effective when applied to a high-risk population. The vast majority of us have screening programs. I would guess that most of these programs are multidisciplinary and would hope that they all include some smoking cessation. And finally, I think there's still some room for improvement, and I think we'll still make some strides in terms of both reaching patients and making it safer for them. I appreciate your time. Thank you very much.
The next